Welcome everybody to the last webinar in our Keratoconus series. I'm Dr. Stephanie Wu and I am going to be your host for this evening. And tonight's topic is management of the keratoconus patient. Okay, so tonight we're going to talk about the keratoconus patient as a whole. Dr. Iden in week 1 did a really great job explaining how to diagnose a keratoconus patient, some of the exciting research that's been going on, some of the really cool pieces of equipment that are used to help diagnose these patients, and the importance of early intervention. So he did such a fantastic job explaining all of that. And then Dr. Wellish also did an incredible job explaining kind of what happens during these keratoconus patients' progression through different surgical options. And he took us through kind of a specific case and kind of what to expect, good and poor candidates. And so my job tonight is I'm going to try to tie it all together. I'm going to try to kind of look at it from our point of view as practitioners, as how we see the patient, how to communicate with them, how to review their treatment options, and then we're going to go over a few of the different treatment options with a few case reports. So this is something that I just really think is very, very important, because a lot of practitioners, they think to themselves, shoot, I don't really know how to diagnose keratoconus for sure, because I don't have a lot of this fancy equipment. So just kind of a few pearls on certain things to kind of think in your head as far as, this is, it's kind of that gut check feeling, you know, this doesn't feel right or something feels funny about this patient. So somebody that has decreased vision, if you cannot get that patient to 20/20 and you've got their prescription and you're refracting them and you're like, something's just not right here, that's kind of like a key, kind of a gut check, you know, something else might be going on. If the patient complains to you that they've got distorted vision or they're seeing double, a lot of my patients will tell me that things seem shadowy. They don't really have double vision, but it's almost like a 3D effect. That's also kind of a trigger of, maybe something else is going on here. Large changes in prescription. So if this is a patient that you've seen for multiple times during the course of their lifetime, if you're noticing that their prescription is changing in large amounts, especially the cylinder component, that's also kind of a red flag for, maybe I should get this patient screened just to rule out keratoconus. If their vision is not achievable to 20/20, especially if they are a previous patient and they were able to get to 20/20 in current years, that's another reason to maybe say, maybe send them out for a quick scan just to see. If you are an optometrist or optician or tech that does retinoscopy, scissoring is one of the key findings for keratoconus patients. So you don't need anything fancy. If you just have your streak retinoscope and you put them behind the phoropter, you'll see that scissoring reflex, and that's another kind of red flag to look out for keratoconus. Of course, if you're doing a slit lamp exam and you see that the cornea might be a little bit thin, or you see some stria, that's also kind of cause for concern. If you notice their Ks are steep, in school we're taught, you know, once they get to 47, 48, 49 on that autorefractor, that's kind of a red flag. But some of the current research actually shows that keratoconus patients can have Ks that are even less than that. So that's not totally the gold standard anymore. More of the research is showing that we need kind of this multifaceted approach to diagnose keratoconus. So if you see any of these other issues, but then you look at their Ks and you say, well, you know, they're normal, you know, they're under 44, 45. And so I would classify them as not being really steep, but you have some of these other symptoms or signs, I would definitely try to rule out keratoconus. Something that I hear a lot from doctors is, you know, I'm in a traditional practice, or, you know, I'm in a commercial setting, or I'm in a clinic where I don't have access to a pachymeter. I don't have access to a topographer, and that's okay. That's why I'm giving you some of these kind of pearls of things to look out for when they come in just for their regular comprehensive eye exams. And if you're really concerned about it, what I would recommend doing is just simply sending them to an optometrist or an ophthalmologist in the area that has some of this equipment, just to get them screened. So if you work with an ophthalmologist already, maybe you're co-managing a cataract surgery or LASIK or something in the area, just reach out to them and say, hey, I don't have the funds to purchase a topographer on my own, and I don't think I would have a use for it, or the ROI is not in it for me, but I want to send some of these kind of suspicious patients. Is that something that I could work out? And I know a lot of ophthalmologists will actually be, they'll be completely okay with wanting to help do that for you. So I would highly recommend, if you don't have the means to get a pachymeter or a topographer in your office, just reach out to other doctors in the area, see if you can work out some sort of system where you can just send them over for a quick scan. That's what I did before I had a topographer, and it worked really well. So now I'm going to go over kind of some of the things that come up during the exam. So let's say that a patient is recently diagnosed with keratoconus. We're going to talk about kind of how to explain the disease to the patient, kind of going over the prognosis of the condition, going over the different treatment options, and having them give them some really high quality resources. So explaining keratoconus, how do you explain this to somebody? So let's say that you are suspicious that they might have it, or you do end up sending them for a topography and you get the results and they clearly do have keratoconus. The way that I explain it is I always show them a picture, or I have an eye model that actually has different corneal shapes that I'll kind of bring out to show them. And I'll tell them that the front surface of your eye is covered with a clear membrane called the cornea. Normally, the cornea is a spherical shape, which you can see in this photo, but the shape of your eye now is more like a cone. So it's more like this shape here. And this is the problem. The shape of this is now irregular, which is causing your vision to be blurry. So that's how I explain things to patients. And I think having just some visuals, either a printout or just something that you can pull up on the computer screen to kind of show them a visual, really helps them understand what's going on with their condition. I always make sure that I explain the prognosis of the condition. I always tell patients that keratoconus is a progressive condition, and that means that this will get worse and worse over time. If you don't do anything, the vision will continue to decline and you'll be at risk for other eye events. And I think this is so important that we explain this to patients, because a lot of times people think that if they don't do anything at all, it's really not that big of a deal. There's a lot of other conditions out there that if you don't do anything, it doesn't have that bad of side effects. You can kind of let it go. But for keratoconus, I think it's really, really important. And it's something that we've learned in the last 2 webinars as well, that early intervention is key. And it's really important to slow down keratoconus, stop the progression, and try to get these patients stable as quick as we can. So I like to also explain the treatment options to patients. Glasses will work just fine for patients that are very, very mild as far as keratoconus goes. Some patients that are mild and they have no desire to use contact lenses, they can absolutely use glasses if their condition is in a mild case, and they can see functionally with glasses. So that still is a good treatment option for some keratoconus patients. Contact lenses, which we're going to go over toward the end of the presentation, going to go over a few different cases. There's lots of different types. There's soft contact lenses. If they have a mild condition, a mild case, they can actually be fit into regular soft contacts, regular soft toric lenses. They might need a custom soft lens or something that's in the extended parameter range if they end up getting to more moderate or some of the advanced cases. And then when they do get to those kind of advanced and severe cases, they really do need to be in some sort of gas permeable lens option. So corneal GPs, hybrids, or scleral lenses. I always explain the surgical options such as cross-linking or intacts. Sometimes if a patient knows they have keratoconus and they come back in and they kind of want to know more, they'll kind of ask me questions about the different surgeries and some of the pros and cons, and they want my recommendations on which ones to proceed with. This was an interesting article that was recently published, and it was about corneal cross-linking versus conventional management for keratoconus, and it was a lifetime economic model. And it really, the crux of this shows that we really need to intervene early, and that's going to not only help with the patient, their vision, but there's so many other things. You know, when patients become really advanced, it becomes a lot more difficult to treat them. When they become very advanced, that increases their chance of needing a corneal transplant. And when they get a corneal transplant, that also causes a lot of issues down the line. And that does not mean that they're going to get out of specialty contacts or glasses. So I think it's just really important. And this is something that really kind of is eye-opening as far as one of the most recent studies that have come out and recent articles showing that it is really important to get these patients treated sooner than later, because throughout their lifetime and even the cost to the healthcare system, it's going to be better for everybody. So another thing is we want to educate patients on what treatment option is best for them. So age is a concern. If they're very young, for me personally, I refer them to get cross-linking right away. We know that if they're diagnosed earlier in life, they're way more likely to become advanced later in life. And when they get to those advanced stages, you know, getting a corneal transplant becomes a lot more of a probability for them. If you diagnose them and they're, let's say, you know, 60 years old, maybe they don't need a surgical option. So kind of going through the different options based on their age. Also the severity, kind of, are they a mild case or are they very severe? So if somebody is very, very severe and they want to wear soft contact lenses, that's just really not going to be the best option for them. So it's important to kind of educate them on why they would not be a good candidate for something like that. Their lifestyle. So if somebody is does a lot of sports or activities, things like that, they're outside a lot, you know, they may not do the best in glasses. They may not do the best in corneal GPs, because corneal GPs can dislodge, and they can, if they're in dusty, windy environments, a corneal GP is known to get foreign body entrapment. So maybe that's not the best option for them. So kind of going through some of the different options based off of their lifestyle, their severity, their age, and then just their current situation. What I mean by that is, if you have a patient and they say, oh my gosh, my kid has this disease, we need to get cross-linking and we need to get them fit into specialty contacts, we just can't do all that right now. What would you recommend? And then depending on the situation, we'll kind of go from there. For instance, if a patient, let's say they just can't do all of that right now and they have to pick one, we kind of go down the route of what we think is best for them. So if it's a kid, I usually make a strong recommendation for the cross-linking first before I end up doing the specialty lens fit. And that's just so we can stop everything. And then as we proceed with the lens fitting, it will be quite stable throughout the lifetime of that patient. But there's some situations where the parent says they need to see well now, and we'll do the cross-linking in 6 months or 3 months or whatever the issue is. So we just kind of have to be real with these parents and these situations and figure out what's going to be best for the family and what's going to be best for that unique patient. There are some great resources available. National Keratoconus Foundation is a nonprofit organization that is committed to helping keratoconus patients. And they've got these free handouts that you see to the right here. There's booklets. If you go onto their website, I think there's a practitioner area where you can request some of these booklets. It's kind of an informative resource for patients, kind of explaining what keratoconus is, why did I get this, Am I going to pass it on to my kids? You know, some of these really common questions. And it's a really good guidebook for them, and something tangible that they can take home after visiting with you. So I like handing out these resources to patients whenever I newly diagnose them. Living with Keratoconus is another great resource. There's a great blog on there, talks about different conditions, different treatment options, and gets some expert point of view. So that's kind of cool. Social media forums, those are kind of good and bad. You know, there's like a lot of Keratoconus forums. I'm a part of some of them, and it's kind of interesting what you see patients posting about. But at least a lot of them, what I have seen is a lot of people, they feel like they are heard, and they feel like they have a group of people that understand what they're going through. And in the past, you may have been the only person in your family that had keratoconus, and your friends. You know, it was, you know, back when the prevalence study came out, you know, 20 years ago, was 1 in 2,000 patients. So that's only, you know, you may never contact anybody that has keratoconus. So no one really truly understands what you're going through. So some of the social media forums have been good for patients to kind of get that connection with other people. The reason why I say it could be bad is because sometimes they go down this path of making recommendations for each other, which giving medical advice and things like that, which really should be done from their eye care provider. But so there's a pros and cons to the social media forums, but it has provided some really good support for some of my patients, and they feel like it's a good resource for them. And then we've got to be prepared for some of these common questions. Why did I get this? Is it hereditary? Am I going to pass it on to my kids? Is anybody else in my family at risk? Am I going to go blind? What if I don't do anything? And what if can I make it worse? And why can't I just wear glasses? These are all really, really common questions that we just have to be prepared for and have answers to. So let's go over co-managing corneal cross-linking. So you've referred the patient for cross-linking. Now what? So let's say you've diagnosed the patient, or you've gotten a topography from another office and they sent it to you, and then you have the patient come back and you explain to them, yes, you do have keratoconus, you've answered some of their questions, and let's say you referred them for cross-linking. This is a typical follow-up schedule. Of course, every surgeon, every eye doctor is going to have a different one, but this is kind of something that people have been asking for. So some doctors, they said from the prior webinars, hey, can you just give us like a quick just synopsis and overview on kind of what we need to expect. So once they have the cross-linking, they might see you the very next day, depending on what your relationship is with the co-managing surgeon. So if you see them the next day or you see them the next week, they're probably going to be on their topical antibiotics, their steroids, and lubricants. Want to make sure we tell them, do not rub your eyes, and you can definitely remove the bandage lens once the epithelium has healed up. Month 1, you might want to do some OCT imaging or tomography topography to see if things have stabilized, check their vision. And if you are comfortable and the surgeon's comfortable, contact lens fit. Month 3, 6, and 12, continued evaluation with topography to see if things have stabilized or if things are changing, check their vision, and maybe fit their contact lens at that point. So day 1, checking their vision, reviewing their medicines, slit lamp exam, and checking the bandage lens. So pretty similar to what we're doing with cataract post-ops. A lot of you guys on this call probably already co-manage a lot of LASIK patients, PRK patients, maybe even some cataract post-ops. So it's actually quite simple. You just check their vision, you review their medicines, make sure they're following the protocol, check them with their slit lamp, make sure there's no obvious defects that you need to be concerned of, and then check their bandage contact lens. If the bandage lens is all crumpled up and it's in their fornix, of course, you can remove that and then replace it. If everything's looking good, then you can just keep that on. Something important to remember about cross-linking and co-managing it is that there's a 0-day global period, meaning that as soon as the patient sees you, you can start billing office visits. You're not having to wait for the surgeon to kind of release the codes to you. You know, if you do a lot of co-managing as far as cataract goes, you know that it's very dependent on the surgeon as well and them getting the codes to the insurance. But it has a 0-day global period. So you are able to bill your typical office visits. And I would recommend 99212 or 99213, depending on the level of complexity of the visit. And if you do have to replace the bandage lens, the 92071. So week 1, we're going to check their case history again, find out how they're doing, make sure they're taking their medicines appropriately. Again, we're checking their vision. We're doing a slit lamp exam. And then if the epithelium has healed up, we'll take the bandage lens off if appropriate, continuing all their eye drops as recommended. Billing, same thing, 99212 or 99213, depending on the level of complexity. And if you do have to replace the bandage lens, the 92071 again. Now they're in for their 1-month visit. We're going to do the case history again, check their vision, do a slit lamp exam. And now, since it's been a little while, we can do our topography or tomography. And we can check their pressure at this time and continue their medicines. Billing, 99212 or 99213. Sorry, that's supposed to say 99213 if appropriate. And topography is 92025. If the patient's stable, it's okay to fit them into specialty lenses again. Or if you're not comfortable with that, or the surgeon's not comfortable with that, then you're going to go ahead and wait a little bit longer, depending on your comfort level and what is happening with that patient. So now I want to go over specialty lens fitting. It's really important to get a case history about their health, their career, and their lifestyle. So next to their corneal shape, their lifestyle is really going to help you as the doctor or the practitioner when selecting the lens design and replacement schedule. So we want to go over what the patient's goals are. What are they trying to see? What have they tried in the past? This is something that I think is really critical to ask, because if somebody has already tried corneal GP lenses in the past and they absolutely hate them, they couldn't get used to them, they were super uncomfortable, I'm not going to reach for that lens again. That's just going down a path that is going to be wasting time for you as a practitioner and the patient. So we'll try different modalities. Other times patients come in, they say, I tried corneal gas permeable lenses and I really liked them. And I liked that they were less expensive than some of the other designs. So then going down that path would be a great option for that particular patient. So there's a lot of different lenses that can be used for keratoconus patients, and they all have their place. When we talk to some of the patients about specialty lenses, I think it's really important to just take an extra moment to discuss with them, you know, some of their fears. You know, what are some of the fears that you have, you know, having keratoconus? What are some of your concerns? What are some of your family's concerns? What are your concerns with contact lenses? Just spending a little time with the patient can really go a long way in gaining the patient's trust and loyalty. If they see that you are really taking time to understand what their issues are and understand what they're going through and what their goals are, what their fears are, I think that really helps establish you and your credibility as their doctor. And I think it really helps them understand that you are taking that extra step to really understand their case, and you really want to help them get to where they need to be. So after you gather all of the exam data, I think it's our responsibility to let them know the different options available. I do feel like as their practitioner, it's important to make a strong recommendation for 1 or 2 different lens types instead of going through a myriad of a million different lenses and then just confusing everybody. That's a mistake that I made when I first got out of my residency. I would tell patients, here's all the lenses we have. We have glasses, we have soft contacts, we have custom lenses, we have hybrids, we have corneal GPs, we have scleral lenses, and that becomes incredibly overwhelming to the patient. So I think after you gather a lot of the information about the patient's lifestyle, their vision goals, things they've tried in the past, kind of understanding them as a person, make one or two very strong recommendations and go from there. It really helps because when you give the patient way too many options, they can become very anxious and then they get nervous that they're making the wrong decision. So that's just a little pearl that I've had from just taking care of a lot of these patients over the years and making that mistake of making all these different options and thinking that that was the best approach. Making sure that you're a good source of information because patients are on the internet. They're on the internet, they're Googling things, they're looking things up. They've got all these ideas in their head of what they think that they should be wearing or what they should be fit with. And it's really important to let them know, it's great that they're looking things up and that they're really interested in their condition, but it's also really important to look at the science and some of the research. And we went to school for many, many years to understand this condition, so we know things that work and things that could sometimes be dangerous, and it's important for us to educate the patients on those. So prepping your office, fitting sets, if you are wanting to go down this path of fitting your own patients into specialty lenses, it's actually quite easy as far as availability. Whoever your lab is now, and if you don't have any laboratories, please reach out to me afterwards. I can connect you with all of them. They're all fabulous. They do such a great job with these custom lenses. Please reach out to me if you really have no idea where to start. I'm happy to help. But fitting sets, if you already have a custom contact lens option, as far as some of your other gas permeable lenses, they probably have a fitting set specifically for keratoconus patients. And if you don't want to commit to it, you can always ask them for a loaner set. You can say, hey, I want to start fitting some of my keratoconus patients, and I'd love to kind of get used to the design. Then you can try it for like 90 days and see if you like it or not. Most all of the labs now have a scleral lens fitting set. So if you're already ordering gas permeable lenses or custom soft lenses through a lab, they all have scleral lens sets now. So you can also ask for a loaner for that too. These scleral lens designs have really come a long way, and a lot of the labs have great designs now. You definitely need tools and solutions as far as if you are going to fit scleral lenses in any capacity. You definitely need to have the plungers, the small and large ones. You need to have non-preserved saline. You have to have sodium fluorescein and some of these other solutions as far as care systems and things if you are going to go down that path. So just making sure that you're stocking your office appropriately. Another question is, do you have to buy fancy equipment? Well, the short answer is not really, unless you are going to take this to the next level and you want this to become something that you really want to incorporate into practice. The best topographer, if you don't have one, is actually a corneal GP lens with a known base curve. If you put that thing on that person's eye and it's touching massively, then you know that the cornea is steeper. So then you can just keep moving up in the base curves until you find something that fits appropriately. So that's just like the poor man's approach to topography if you don't have anything. But you don't absolutely have to have all this fancy equipment. You can always refer to other doctors to get some of the images that you need until you have enough funding to be able to purchase them on your own. So right now, when you fit keratoconus patients, what is your kind of go-to modality? And I know that you may have a lot of these different options in your office, but I'm just curious from my own knowledge, kind of where people are at as far as what kind of lenses they are kind of reaching for to begin with. What are you saying? All right, they've got keratoconus, and I'm going to fit them with a contact lens. So it looks like a majority of you are fitting patients in scleral lenses, followed by corneal GPs. So that's great information. Thank you so much for sharing this with me. this is really good information. Just kind of moving through the series so we can kind of see what practitioners are interested in and kind of what they're comfortable with. So first, let's talk about soft lenses. Early keratoconus patients are actually able to wear standard soft lenses if you catch them early enough. It's really important to let the patient know that it is a progressive disease and the prescription will change, especially if they don't end up getting cross-linking. So while they will be able to wear these early on, it usually will not be a viable option long-term, especially if their condition keeps progressing. A lot of keratoconus patients are able to be fit into more custom soft lenses, and there's a lot of different options on the market. Again, if you kind of talk to your laboratory or look up soft keratoconus contact lenses, there's a lot of great options out there. And I definitely use them for patients that maybe don't tolerate some of these other lenses well, or maybe they're not as advanced, so I don't have to go to a scleral lens necessarily. And a lot of these custom lenses have good return policies, which is something that is important. So a lot of patients are worried that if they go and they pick the wrong design or they can't see well, that they're not going to get any of their money back, or they're not going to be able to try anything else. So that's something that I always like to go through with patients is what's the return policy, and kind of can we go to a different lens design if this doesn't end up working. So just have a case report from a patient that we saw, 33-year-old white female. She was diagnosed with keratoconus in 2019. She had corneal cross-linking in her left eye in 2020, and she did not have any plans for the right eye as far as she was concerned as of this moment. She did complain that she had strained vision, she had double vision, and she had headaches. With her spectacles, she could see 20/40, but she said it was very doubly and very shadowy in the right eye and the left eye. So here's a picture of her topography of her right and left eye. This is more of a mild case, but she had done a lot of her own research. She was actually a physician's assistant, so she's in the medical community, so she had done a lot of research and talked to a lot of other doctors, and she wanted to be fit into scleral lenses. So that's what we did at first. We fit her into scleral lenses, but every time she came in, she told me, these are so dry, I just want to rip these out of my eye. I don't know what the problem is. We looked at the fit, it was perfect. The fluid layer was perfect. We tried changing the material of the scleral lens. We added hydropeg coating. We changed the filling solution. So we did basically everything that we could as far as a contact lens component. Still no effect. We also added in Restasis and some other lubricating drops, checked her in a month, really no change. So then we refit her into a hybrid lens and then ultimately a soft lens. So here's the hybrid lens here, if we can get this to play. So you can see hybrid lens, it's a gas permeable lens in the middle with the soft contact lens skirt. And this actually fits her eye very well. But within 5 minutes in the office, she said, I'm having that same feeling. I have to rip this thing out of my eye. It's so uncomfortable. So then we said, okay, we're going to try something else then. So then I reached for something called the Kerasoft Thin, which is a soft custom lens for keratoconus. And first I fit her into the 8.6 base curve. And you can see kind of when she's looking around, the contact lens is sliding a lot. So not like a typical contact lens fit that I would prefer to see for a patient like this. So with this type of lens, you don't want it to slide around a ton. That means that the lens is a bit too flat. So now we fit her into an 8.4 base curve, so something a little bit steeper. And you can see it's moving a lot less. It's pretty well centered. It's not moving nearly as much as the other lens. Just for fun, I fit her into the 8.2 base curve. but you can see there's a very large bubble there. So now I know I've gone too steep. So it's kind of a good way, you know, they've got a lot of different options in the fitting set, but for this patient, it was easy to figure out that she ended up needing the 8.4. So we ended up fitting her into that lens, and we just did an over refraction, and she was able to get to 20/20 by adding in a little bit of cylinder. And so we just added in that exact prescription and got her to where she needed to be. So here's a patient where they've got keratoconus. We tried a scleral lens and it just did not work out. If you fit these types of lenses to any capacity, you will find that there are patients that they just don't do well with scleral lenses, so you have to have another option. Gas permeable lens options. I know a lot of people think that they're dead, but they definitely are not dead. Gas permeable lens options offer very good vision for early to very advanced cases of keratoconus. Something that we need to know is that the lens bears entirely on the cornea. So some of the good and best candidates are nipple or oval cones, patients that are wanting a lower cost option. Gas permeable lenses, corneal GPs in particular, cost less than hybrid and scleral lenses. So they are a lower cost option for patients. So sometimes that's really important. So we've got to consider that. And other patients that maybe they've tried and failed in other modalities. Some of the risks that we have to be aware of with corneal GPs is that apical touch, especially significant amount of apical touch, can lead to scar tissue. And what happens if they're lost to follow-up care? This is something that's happened to some of my patients where I have fit them and I am positive they've got a beautiful 3-point touch with the lens that I have fit. And then I don't see them for 3 years. And then they come back and they're like, oh, I got busy. I forgot this and that. And now their keratoconus has progressed. And now the lens is fitting super flat. So now they're at risk for scar tissue and all sorts of other issues. So you have to realize that that could also be an issue that comes up. In the CLEC study, there's so much amazing information that came out of this. But if you remember from the CLEC study, we found out that the keratoconus patients that were fit in lenses that were very, very flat had more scar tissue on the cornea compared to the patients that were fit in steep designs. So that's always something in the back of my mind as well. You know, am I sure that this patient's going to follow up? Are they going to come back every year for me to adjust the design? What if I lose them to follow-up care? What's going to happen to their cornea? So let's go over a case report. We had a 34-year-old Black female that has keratoconus. She had corneal cross-linking epi off in May 2020, and then in the right eye, and then August 2020 in the left eye. She uses sustained tears and oasis tears as needed, and she complains that her eyes are really blurry. She's got double vision, and she's got very sensitive eyes to light. She hasn't used any glasses or contacts at all. Her uncorrected vision is 20/50 in the right eye and 20/100 in the left eye. Here's her topography on the right eye. So you can see her K max is about 60 diopters. So I would say, you know, moderate case here. So here's the first lens we tried on. It's a Rose K, a very classic GP lens for keratoconus patients. 6.2 base curve, 8.7 diameter. And when I look at that, I think, that's a little bit too tight for me as far as it's touching a little bit too much on the cone. So I wanted to see what happened if I steepened up the base curve. Now with the second lens, we did a 6.0 base curve, and this one looks better, but it looked a little bit too steep. So then I ended up going with the 6.1 base curve, which looked a lot better to me compared to the other two. So again, just kind of bracketing the different lens options and getting something that fits on the eye fairly well. And at least you have a starting point. And that way you can kind of see, is it touching too much? Okay, let's go steeper. Okay, is there a bubble? Am I getting way too much pooling? Okay, let's go flatter. So with this patient, we ended up ordering the Rose K2. Based off the video, the consultant said, yeah, the 6.1 looked good, but let's just go a hair steeper. With the over refraction, she ended up seeing really well. And then the last case report is scleral lenses. Scleral lens patients, the reason why a lot of practitioners and patients go into them is because the comfort is really good compared to some of the other modalities. Are they easier to fit than corneal gas permeable lenses? Depends on who you ask. If you did a lot of corneal GPs in school, then you're a lot more comfortable fitting corneal gas permeable lenses. If you didn't do a lot of corneal GP lenses and you did a lot more scleral lenses, you feel more comfortable with scleral lenses. So I don't think one is easier to fit than the other. I think what ends up happening is you really have to understand the disease of keratoconus, because that's what the difficult part is. Seeing these patients for their follow-ups, troubleshooting the lens designs, that's where all the issues could come up. So I'm not sure if one is technically easier than the other. Just depends on your comfort level as a practitioner. One of the benefits is that you don't get lens dislodgement, you don't get foreign body entrapment, and that fluid reservoir from the scleral lens holds that liquid to the eye all day. So really, really good for dry eye patients. In fact, it ends up being a really good treatment option just for dry eye patients in general. And it's really given us the ability to fit these very, very highly irregular corneas. Some of the keratoconus patients that have very advanced cases, they're very, very hard to fit with corneal GP lenses. They're constantly popping out. They're constantly having edge lift. The patient's complaining all the time. In that case, scleral lens could be a really good option for them. This is a great study that was done, and I always refer to this. It's such a great study that I like to share with a lot of my ophthalmology colleagues. Scleral lenses reduce the need for corneal transplants in severe keratoconus. This is a really cool study that was done. If anybody needs a copy of this, please feel free to message me. I'm happy to send you the original, the full paper if you wanted to read it or share it with your colleagues. But this is great because it kind of shows that with severe keratoconus patients, instead of going down the route of corneal transplant, try them in a scleral lens first and kind of see where that takes them and see if they get acceptable vision. So let's go through our scleral lens case report. We had a 38-year-old Hispanic male referred by his ophthalmologist for a contact lens consult in his left eye only. He does have a history of keratoconus, and he wore gas permeable lenses for 10 years, but he complained that they were always popping out and that they were always uncomfortable. So he wanted to see if there were any other options. His best vision is 20/80, and you can see here in the picture he does have a corneal scar. We discussed different options with him, and he decided he wanted to go for the scleral lens option. So we ended up doing a corneal scleral topography on him. So basically, we're capturing the scleral shape, so where he's looking up, down, and straight ahead, and we're taking all of these measurements and using that to stitch an image so we can see where the elevation is on his eyeball. So this is the elevation map. So similar to us as eye doctors, we're used to seeing corneal topography, but this is something kind of newer. It's scleral topography. This shows us areas that are more or less elevated. So you can see kind of in the nasal and temporal side, that 3 and 9 area, you can see that those areas are more elevated, especially that nasal area where there's a small pinguecula. So it's really cool with some of this technology. When you're designing these custom scleral lenses, you're able to kind of vault over those areas and get them into something that's very comfortable. Fit him into a diagnostic lens, and with an over refraction, he was able to see 20/30. Here's just a picture. You can see kind of the 3D mapping of kind of what the lens looks like on the eye. On that nasal aspect, you can see there's that small pinguecula, and the lab is taking into consideration that area and making sure that that area is more elevated. Lens dispense here, he's seen 20/30. The alignment and the centration look really good. He said the comfort was excellent. No significant over refraction. We then again saw him in 2 weeks, 1 month, and 3 months later with really no change. So scleral lenses, amazing option for keratoconus patients. Lastly, glasses. Do they even need glasses? Is it even worth it? I tell patients this is something for if your house catches on fire, you reach for your glasses and you get out. It might provide some functional vision. Most keratoconus patients will never wear their glasses unless it's an emergency or they have some sort of eye infection or they lost their contact lens. But I always encourage them to have a backup pair just in case. And I just wanted to kind of review just a few little pearls on managing patients behind the scenes. If you are managing these patients with specialty lenses, please make sure that you have some sort of agreement or a contract or something written down that says exactly what the process is going to be like and the fees involved. This is super important to get in front of them before you even do any sort of fitting at all. We need to make sure that you've got things like payment plans, how much time is going to be spent for these visits, how long is the fitting duration expected to last, and what happens if they don't work out. Do they get any money back? Can they go back to glasses? Can they go back to some other design? This all needs to be clearly stated before you go into the contact lens fitting, because personally, I have had many, many cases where for whatever reason, the lens did not work out for that patient. It was through no fault of anybody's, it just didn't work for that patient's eye. So what happens in that case? Do they get a refund? Do they get a partial refund? You know, that all has to be very, very clearly explained before you go down that path. Make sure that you're organized with either patient trays or a certain area where the lenses are kept, organizing your invoices, making sure that there's somebody in your office that's keeping an eye on some of these orders. It's really easy for you to forget about it and forget that these lenses are here, and then you go to exchange them or return them and it's too late. So make sure that you also are pricing things fairly. And what I mean by that is make sure you kind of go through and say, all right, I'm going to spend X amount of time with this patient for the fitting, X amount of time for their dispense, their training, all of their follow-up care. So you need to make sure that you are pricing it according to what your time is worth. For lenses, I always get questions on how to price lenses. I think a good rule of thumb is it's another cost of goods. So if you're already selling glasses, soft contacts, anti-glare coatings, transitions, you know, whatever you're selling in office, price it similar to some of your other cost of goods. So just some clinical pearls: develop a plan before you see the patient, before you kind of go down that route. Consider some sort of agreement or outline to go over the fitting process and what all the fees are. Reviewing the different treatment options with the patient. And then if you are going down that route of contact lenses, try to select a good lens or make a strong recommendation for one specific lens or two lenses to try to limit the amount of follow-up care and exchanges and reorders. The patients, once they know how complex this process is and how custom it is, they're really appreciative of your time and the expertise and the knowledge that comes in with fitting these lenses. And I think I will end it there. If you have any other questions, please feel free to reach out to me. And thank you so much for attending the Keratoconus Symposium, and we'll see you next time. Good night.